Hello to all our Three North friends. This is Ada. I am appearing to you by the magic of technology as I'm unable to make it in today. But I wanted to share this video with you as it's basically a presentation I put together for other meetings that shares some information on how to sort of look at CIWA with a fresh lens and try to improve our success in the care of our patients who are experiencing alcohol withdrawal. Something that, if we're honest with ourselves, we can always do better at, not for a lack of effort. So thank you for being here at this mandatory meeting. And without further ado, again, I'm Ada Fisher, RN, CCRN, CCM, which is obviously Cool Cat Mom, and there she is in all her glory, Pancakes, who might actually walk in front of the screen at some point, and I sure hope she doesn't mess it up. So I'm Ada, 7 years of nursing all across the hospital, currently working with emergency and rapid response. Also, probably I would identify most as a critical care nurse. It's my passion. Yet I've worked in a lot of different areas, and in all of these areas I've worked with patients in alcohol withdrawal, and so that's kind of what brings me to be a nerd on this subject. Also a nerd about cats, music, cooking, and outdoor adventures. If you know anything about me, I'm obsessed with skiing. Okay, so what I want you to take from this presentation, if possible, is to explain what's happening in the brain during alcohol withdrawal. Tell me how we actually treat withdrawal and why the pharmacology works. And then to understand the actual CIWA protocol, where it really comes from, and what we're really assessing, and how to use it correctly. So we're going to start with a little story. Okay, so you've got your patient. She's coming out from the ED. You get a report, grandma, 72-year-old female, drinks, quote, a little, end quote. Turns out this is about a box of Sauvy Blanc. Boards in the ED for a day and a half. CIWA has been ordered this whole time. It's kind of vague if they've really assessed her or given anything. It's been a really hectic time down there. So she's alert and oriented ×4, a little shaky, blood pressure is a little high, systolic 170. You kind of think, well, yeah, she's old, shaky, hypertensive, it looks okay. She's at the bottom of my priority list. I got a bunch of meds to pass. So as you're passing your meds, you hear a little commotion down the hall. Turns out grandma here is wilding out, and you whip out your CIWA tool to calculate her score, and you find she's about a 29. So your friend rushes down to grab you Ativan, but it's not really helping yet. You give it. You're hoping it'll kick in. Nothing's working. You're sweating bullets. It's been like 25 minutes. Grandma's one head spin away from needing an exorcism. So you call RRT as a consultation and explain the situation you're dealing with. Now, of course, right before Rapid walks in, about 30 minutes later after you gave your Ativan, grandma looks great. She is sitting in her bed, she's doing her crochet. Who gave her the crochet needles? It's sketchy, but that's okay. She looks good. So it's shift change. You look haggard, you give report to the next shift, and the oncoming shift sees her and says, okay, yeah, I know, she looks pretty good. That's okay. So they're chatting at the nursing station, kind of, putting off med pass till a little later. And all of a sudden, grandma's back. Commotion down the hall. Those receptors in her brain are screaming for some GABA stimulation. We'll get into that in just a moment. So that story may sound familiar, and we'll come back to it at the end. But first, let's talk about alcohol withdrawal pathophysiology. What's actually happening in the brain? So obviously to the brain mobile. So a couple of key terms here. GABA. When we say GABA, we want to think downer. When we say glutamate, we want to think upper. These are let's see here. GABA will be an inhibitory result from stimulation, whereas glutamate will be an excitatory result from stimulation. So what we're really talking about is receptors here. So our GABA receptors, when they're stimulated by any number of things that they have a receptor for, they're going to have an inhibitory effect, a downer, chill vibes. Whereas a glutamate receptor stimulated by anything it has a receptor affinity for will create an uppity vibe, excitatory. And GABA in particular has a special parking place for alcohol. Okay, so everything is about balance in the brain, in the body, and in this case, in a very simplified but accurate look at this chemical balance, GABA is going to balance glutamate. GABA receptors, when stimulated, are inhibitory, and glutamate's excitatory, and the two balance each other out. Now, when you start adding on a bunch of alcohol to the brain, we're bathing the alcohol in brain, and alcohol, like we saw earlier, stimulates GABA receptors, creating two chillville, downer vibes, inhibitory effects. One night of this, and you're just, it's a Saturday night, and you had a long work week, and now you're just tossed. If you have this stimulation over and over and over again in a constant manner, the brain is going to react. And how does the brain react to keep balance? Well, it's going to start down-regulating those GABA receptors in order to seek balance, as well as increase the glutamate receptors to achieve a new balance. So, as you can see, we've achieved balance through both the downregulation or reduction in GABA receptors available in the brain, literally reduce the number of physical receptors, and increase the physical number of glutamate receptors in order to balance the excessive inhibitory stimulus of alcohol. So, this is great. This isn't healthy, but this is balance. And why the brain has done this is to protect itself, because too much excitatory stimulus leads to imbalances like seizure activity and other neurodysregulations and neurohormonal dysregulation. So here we are, temporarily safe and in balance. Now, what happens when you take that brain that's relying on this daily source of alcohol and put them, let's say, in the hospital or in prison? In our case, we're talking about the hospital, but any kind of situation in which you have an abrupt cessation of alcohol. Well, seems fairly obvious. The balance falls in the opposite direction towards the excitatory picture, and we have a big problem. What does that chemical imbalance look like? What does it look like when we have this brain goes boom, excitatory overload? We've ripped away the alcohol, the balancing scale has fallen towards the excitatory, and we see CNS hyperexcitability. This is, for example, seizure activity or sensitivity to stimuli. We see autonomic nervous system hyperactivation, which sounds like a tongue twister, but what we're talking about here basically is the fight or flight picture. Catecholamine surges, tachycardia, hypertension, fever, flushing, diaphoresis, GI upset because the GI picture is all parasympathetic, and so here we are flooding our body with a neurohormonal dysregulation. And then in extreme and often in addition to the above is delirium tremens, which is agitation, hallucination, clouded sensorium. This is the, pink elephants dancing, spiders in the corners, all kinds of very intense and bizarre hallucinatory or delusional thoughts. And so you might say, wow, that sounds awful familiar. Things like, clouded sensorium, tremors, sensitivity to light, nausea. Well, it is familiar. This is all of the symptoms that the CIWA protocol is built upon. We'll come back to that in a moment, but I want to talk about what do we do, once we realize withdrawal is happening, once we realize this brain has become chemically dependent on alcohol and is now in an imbalance because we've stopped that alcohol intake. Well, here we are in that imbalance I just described. How can we rebalance the scales? Well, yeah, we could give them booze, absolutely. In fact, that was common treatment in the past and currently is still a common treatment and is not necessarily a harmful treatment. In fact, it can be quite simple and quite safe for people if they don't plan on stopping drinking. However, we're not handing out natty ice at PSL Southwest, so next best thing, one could argue, but a pretty solid go-to for the most of the world of medicine is Ativan or another benzo. So Ativan's a benzodiazepine, and when we put Ativan into our system, it too crosses the blood-brain barrier and saturates the GABA receptors, albeit on a different part of the receptor. And while it doesn't hit every aspect of the receptor stimulation that alcohol does, it will help us to, at a certain drug level, get back into balance. Remember, what we're balancing is our upregulation of glutamate receptors, our excitatory picture, our CNS hyperactivation, our neurohormonal dysregulation, and even our delirium tremens, which was caused by that imbalance. So here we go. Over time, as we give Ativan to our patients, we're slowly able to reduce the dose of treatment as the body readjusts and downregulates glutamate receptors and upregulates GABA receptors, and eventually resumes a more or less normal and healthy balance between excitatory and inhibitory tone. Voila. Now, CIWA protocol. We pretty much have talked about everything that the CIWA protocol is based on in looking at both the pathophysiology of withdrawal and the pharmacology of treatment. So let's look at how the CIWA protocol works and doesn't work. You can see here there's some vertical lines. This is roughly your Q-hour time interval. So what we're going to look at is what happens in contrasting our CIWA symptoms to the drug level achieved by treating our patient with Ativan. So here we can see that the patient in withdrawal has distinct lack of receptor stimulation for their GABA receptors, and is starting to have this excitatory spike in their symptoms. And because of that collection of symptoms that you've assessed with your CIWA tool, you score them at a 17, which clearly indicates that they are due for some Ativan. So we give Ativan at this point, and we can see that as the drug level of Ativan builds, our symptoms decrease. It's not linear. Ativan can take a while to come on board, as we saw in our story earlier. But for a simplification's sake, we see a drug level rise as our symptoms decline. However, in your protocol, it will say give the drug and reassess at a certain interval of time. So we reassess and we see they still score, and that score still indicates an additional dose. So that dose is given, and their drug level continues to increase. As their drug level increases, their symptoms decline. And when you reassess per your protocol of CIWA in an hour, you see, wow, yay, they're at a 2. So this relationship shows you that their drug level, based on their symptoms, which will be unique to each patient, is directly related to their symptom suppression. So over time, it says, okay, now you can reassess in 4 hours, and as that drug level falls, their symptoms will likely increase. However, we haven't come back up to this 17 from earlier, which was looking pretty sketchy. We're back up at a 10 at the 4-hour reassessment mark. We document our score of 10, our vital signs. We might be seeing some tachycardia, a little hypertension, and we dose them according to the protocol and give them a little more drug level. As that drug level rises, their symptoms decline, and what you can see here is we haven't quite reached 0 every time. We don't want to give them Ativan and then let it fully wear off and their symptoms spike high, and then I create this yo-yo effect or a roller coaster. What we're really looking for is if we accurately assess our patients and we keep track of the time intervals of reassessment and dosing, well, the patient's physiology itself will guide a effective treatment, and it'll keep some reasonable level of drug and reasonable suppression of symptoms. Now, what we hope this looks like over the series of a couple days, if it's working, and this is very theoretical here, but just for the general idea, what we see here is at the beginning there might be a high frequency of attention, dosing, assessment, reassessment, and fluctuation in their symptoms, while when we eventually sort of find the rhythm of what level of drug their physiology is requiring to keep their symptoms controlled, their symptoms and scores therefore come into sort of an even line that declines over time, and likely they need less and less medication as their body sort of moves through withdrawal into a new homeostasis. So that's kind of represented by this sort of frequency of dosing at the beginning with these higher scores, and ideally we find this gradual decline in scores and symptoms as we maintain and then slowly reduce our drug level. What we see if CIWA fails, and this is probably why I'm here today, to be honest, because this is the most classic issue that we struggle with, and it presents both a ethical and a safety issue for the care of our patients, and it also makes nursing very difficult. This is something I like to call the yo-yo. This is where we have a patient who ramps up. You all of a sudden are like, I have 4 other patients, this patient's losing their mind, I'm freaked out, and I'm kind of irritated, I don't know what's going on, I'm going to give them Ativan. Okay, so like half an hour, 45 minutes later, maybe they're sleeping, or maybe they're just acting normal, and you're like, phew, thank God, I gotta go take care of my other patients. You with your best intentions, you happen to miss that hour reassessment, maybe even miss a Q4 reassessment, and all of a sudden they're a huge problem again, and they look bad, and they're sweating, and they're shaky, and they appear behavioral, and so you give them more Ativan, and they calm down again, and then it's shift change, and then they really ramp up on night shift, and they call code gray, so they end up dosing them, and they dose them an hour later, and then they crash and start, snoozing, and you're worried about their airway. So like this up and down is very predictable based on the pathophysiology we talked about, and it's understandably difficult for nursing to keep up with this protocol, but this is what happens when we fail our CIWA protocol and our patients. So one other note is it doesn't always look like just the first or second example. The third example generally is a patient who, despite your accurate and constant assessment, dosing, reassessment, dosing, continues to have increasing and often rapidly increasing symptoms. This patient quickly, your assessment and accurate documentation will be your form of advocacy to ensure that this patient is obvious to you and your colleagues in a timely manner, gets on our radar for rapid response, and is absolutely headed for the ICU, because The CIWA protocol plays with 2 to 3 milligrams of Ativan and intervals at up to 1 hour apart. But this patient might need a lot more assistance with their neurochemical imbalance. They might have essentially the need for a huge amount of benzodiazepines or other forms of sedation to protect them from seizure and delirium tremens. So ICU time, obviously, at the point where their score is skyrocketing, but even when their score was perhaps somewhat reasonable for your floor, if it's reasonably for your floor just after a steady stream of dosing every hour, then you're probably gonna need some backup, and that patient probably could use ICU. So consult rapid response. Talk to your charge nurse. Most important thing is you have to have that CIWA protocol done correctly and documented correctly, because that's your way of saying, see, look, I've been doing everything that CIWA requires for my patient and they need more. So the big idea. We got to think of CIWA as essentially a way to make our nursing assessment and drug dosing algorithmic so that we can maintain an effective drug level in their bodies that suppresses their withdrawal symptoms. The biggest picture is that we're trying to keep our patients safe from seizures, safe from CNS imbalance, and we're also trying to keep them awake and free from harm. So this is about good nursing care and safety for our patients. If you're concerned, we're concerned. At any point, please remember you can call Rapid Response. You can give us a ring on Vocera, ask for Rapid Response nurse or anyone by name who's working, and just ask questions. If you have questions, we'd love to have a conversation with you. Of course, if your concern is immediate, absolutely call Rapid Response, or reach out to your charge nurse for feedback. We're happy to support you. This is something we see all the time, and yeah, I'm very grateful to be here today, so thank you. And I wish I could answer questions right now. I'm going to leave you in the trusting hands of the folks who are leading the meeting, Debbie, and whoever else is in the room, because I can't see because I am recording this last night. Okay. Thank you all for your understanding and for dealing with my very lo-fi version of a presentation. Have a great day. Bye-bye.